Hello and welcome to the Home of Medicine podcast with me, Dr. Amie Burbridge.
And me, Dr. Ben Lovell.
Ben, how are you?
I'm fine. I think I'm a bit better than you because I know you've got a slightly sore throat, but you're powering through and your sound quality is going to be fantastic.
Yes, I'm going to
Signal to
power on
me if
through.
you're failing, and
Yeah.
I'll interpret your facial expressions for people listening.
Excellent. Thank you so much. So, I've got a case for you.
Yeah, go on.
So, this is actually a patient I only saw yesterday. It's been a very busy clinical week. I feel that winter pressures have hit actually quite early. If there was ever really an easing up of the admissions
Mm.
that we're getting through acute medicine, I'm not sure whether that's something that you've noticed as
Hmm.
well.
Yeah, definitely.
And yesterday was again very similar. It was a Monday, very heavy, lots of admissions. But this was a very interesting case for many reasons. And I want your thoughts and suggestions, please.
Okay, I'll do my best.
So, this is a 62-year-old female. And she presented to our same day emergency care yesterday. However, had actually been seen 3 days previously with the same presenting complaint. Initially presented with a 5-day history of a headache. The
Okay.
headache is a sharp headache on the left hand side of her head only. And she pointed sort of over the left eye to the temporal region. And she described the pain as shooting into her ear. When she was initially seen, she said the pain was 7 out of 10. She took paracetamol, she took ibuprofen, and felt that the pain came down to about 4 out of 10, but was still a sharp pain. She denies any blurred vision, no slurred speech, no limb weakness. She said her eyes felt congested, and on further questioning, she'd seen an optician in January of this year who'd said, "You need some reading glasses," although she hadn't actually gone and got some reading glasses at that point. Few days prior to this, she'd had a bit of a cold. So she describes blocked nose, then a runny nose, just felt generalized muscle aching, and describes a heaviness in her muscles, pointing to her shoulders and her elbows. She was really worried that she was having a stroke. And actually, I find it a really valuable question to ask patients. Why have you come to hospital today? What's the main reason? And what are you really worried about is going on? And she was really worried about a stroke. I'm going to leave it there and ask for some thoughts, please, Ben.
Okay. I quite like headaches. No one else,
Okay.
no one else likes them, but I quite like them.
Yeah.
So 5 days of a headache. So let's work through my little algorithm. I'm going to first of all just make sure she hasn't got what we call a serious secondary headache. And by
Okay.
serious secondary headache, I want to rule out subarachnoid hemorrhage, which would be a thunderclap headache. And I want to also think about temporal arteritis or giant cell arteritis. So first of all, subarach, I don't think this is because you would have told me if she'd had a thunderclap headache. Um, but tell me a bit about the onset, just so that I know.
So the headache had been there for 5 days by the time she'd actually even presented to our same day emergency care via her GP. The headache was a gradual onset and it was worsening on the left hand side that she noticed on waking one day. She denies thunderclap, sudden onset of headache. She denies maximum pain, reaching like the worst pain ever, like 20, 30 seconds after onset. She denied all of that. And it did sound very much like a gradual headache that had got worse.
Mhm. Okay, that's all I need to know. So it is not a
Okay.
subarachnoid hemorrhage. Tick, done, forget about it. The next serious
Okay.
secondary headache would be an inflammatory headache. So I'm talking about giant cell arteritis. She's 62, bit young for temporal arteritis, but not it's okay. Usually it's in your sixth or seventh decade. And she's the right gender because it's preponderance for women. And there's this history of a virally malaise preceding this, but I wonder if I could hammer this out to be a bit of PMR because you did mention some proximal muscle weakness or pain. I can't remember if it's weakness, pain, or stiffness, but I'll ask you a few more questions about that in a minute. And when I'm thinking about whether someone's got temporal arteritis or not, I want to ask about any vision changes. I think you said there was no neurology, but just be absolutely sure there's no visual loss, there's no jaw claudication on that side. Is the temporal region tender? Does she have a thickened, pulseless temporal artery on that side? Does it hurt when she brushes her hair? So those are the sorts of questions I'd be thinking about for to rule in or to rule out temporal arteritis. So any of that activating any alarm bells or not? Any of those questions?
Yes, interestingly. So she says she wears a wig. She said, and when she brushed her hair, when she placed it, she felt that the left side was really tender and painful. There was no, she couldn't feel an obvious mass or anything that was, pulsatile or non-pulsatile in that region, but she did keep to that temporal region. She denied jaw claudication on direct questioning, and she denied any chest pain, any shortness of breath, but she did say that she had some tenderness in the shoulder girdle region and around her elbows as well, but denies any symptomatology in the lower limbs. So she could still walk up the stairs. She could still go from a sitting to a standing position.
Pain and stiffness, or just pain?
Pain and stiffness. But that had only been there for a couple of days. She felt generally stiff in that area, but again, not in the legs. But the pain and the tenderness was the main concern.
Okay. And worse in the morning, or she didn't notice?
No particular
Okay.
change.
All right then. So I'm going to park that for a moment because that's potential for me. You've mentioned,
Okay.
you said the tender scalp was the left side, which is the same side of the headache, right? Yep. Okay.
Yeah.
So that's a maybe. So I'm going to be thinking about doing is ESR, CRP, checking her cranial nerves, because you can sometimes get these funny cranial neuropathies with temporal arteritis as well. So I'll do full cranial nerve exam in a moment, but that's a maybe. And in terms of other secondary headaches, maybe a less serious one, I don't think there's any signs there could be medication overuse headache from the history that you've mentioned. Maybe she had a recent viral infection. You can get really bad headaches, secondary to a virus. And is it TMJ dysfunction? Because you mentioned a tender temporal
Yeah.
area.
Good.
So I always just put my hands on both of their jaws on both sides when I'm wondering about that, and just ask them to open and close their mouths a few times. And people with TMJ dysfunction, you can feel and hear the clicking and cracking sensation. I've got it really badly, which is why I'm quite sensitive. Yeah. And ask them if they grind their teeth on one side, because that can sometimes give a really painful temporal region, which can mimic temporal arteritis. So that's my thoughts about that. In terms of, could it be a primary headache, tension type headache, or migraine headache disorder? Bit weird for an index presentation at her stage of life to present like this. So that's much less likely. And then finally, I'm thinking about the rare stuff. You did mention her eye, and her eye was involved, and it went to her ear, and her eye was a bit congested. Just thinking about the trigeminal autonomic cephalalgias, the trigeminal headaches, like cluster headache. Doesn't usually present in women in their 60s. In fact, I don't even know it does, but it can cause horrendous pain that is around the eye, and some autonomic symptoms such as tearing and injection of the sclera. So those are the other things I'd be looking at and asking about. I've basically just given you my headache presentation talk, which I give to people, sorry, in a very abbreviated form. But hopefully where I stand now, I'm thinking about temporal arteritis, and I want to do some more examinations and blood tests. Does that make sense?
Yeah. And I think the way that you worked through that was really nice and systematic, actually. And I think that's one of the role of an acute physician is to rule out the really serious, what is going to really harm that patient today within the next few hours. Subarachnoid hemorrhage. Okay. Giant cell arteritis. And we need to work through that. So would you do a CT head?
Let me think for a second. Not right now. No.
Okay.
I haven't done basic tests here. I haven't really done a full examination or looked at any blood work or examined their vision. So I wouldn't go to cross-sectional imaging yet. when I think about cross-sectional imaging, I'm worried about this insidious onset headache over several weeks, which is getting worse and has symptoms of high pressure. So worse when coughing, bending over, worse in the mornings, waking up at night, makes them feel nauseated. Maybe they throw up a couple of times. And sometimes I think about doing a CT venogram, but I think they've got a venous sinus thrombosis.
Okay.
I mean, maybe if she'd had a recent sort of viral illness that made her slightly more prothrombotic, but at the moment, I'm not ready for my scan yet.
Okay, fab. So I'm going to give you some examination findings then.
Go on.
So her respiratory rate was 18. Her blood pressure was 153 over 98. Saturations were 98% on air. Her temperature was 36.7. Chest was clear. Heart sounds were normal. Abdomen was soft and non-tender. Her GCS was 15 over 15. Examining the power in her upper limbs and lower limbs, it was 5 out of 5. And actually, on examining the temporal region, it was very tender on the left-hand side in the temporal region. The right-hand side wasn't tender. There was no scalp tenderness noted. And aside from that, cranial nerves were completely normal. There was nothing of note. When you looked at the eye, both eyes looked congested, but there wasn't anything significant. And as mentioned before, she hadn't noticed any changes in her vision that were significant. So examination didn't really, I suppose it helped, but, I guess still sort of thinking down the lines of giant cell arteritis, like you suggested.
Yeah. So I'd like an ESR and a CRP now, please.
ESR is 100.
100. That's neither fish nor fowl, really. ESR does go up with age, but 100 is elevated. So, and a
It is.
CRP, did you do? No.
12.
Oh, I quite like this now for temporal arteritis. I'm trying to remember what the guidance is for making a clinical diagnosis of temporal arteritis. You've got to have, I think, 3 out of 5 criteria. One of them is an elevated ESR. One is, I think, the classic pain. Actually got the third one. Maybe the right age range for it as well. But I think you've got enough evidence now to move down whatever your local temporal arteritis pathway is. I know locally for
Absolutely. Yeah.
us, we
Yeah.
can start them on steroids here and now. I remember someone telling me
Yeah.
when I was learning about temporal arteritis, they're saying, look, when you're treating this, shoot first, ask questions later, i.e., get the
Yeah.
steroids in
Absolutely.
them now to save their vision. Don't worry about the biopsy. The
Yeah.
biopsy, as long as it's done within 7 days, will remain positive, even with steroids on board. And back in my day, when
Yeah.
I was a young man, we used to give them pred. So we
Yes.
I think 40 milligrams of pred, but if they had visual changes, we give them 60. But I think now, and
Yeah.
if I'm wrong, they tend to get pulsed with IV methylpred.
Absolutely. Yeah. And that's the guidelines. The British Society of Rheumatology have really good, clear guidelines on the management of giant cell arteritis. And if you think that if there is visual changes or impending visual changes, you do give intravenous methylprednisolone. And it's really important, as you said, to follow the local pathway. Get a rheumatologist involved, get the biopsy or ultrasound scan to see if there's any changes
Yeah.
within the temporal arteries. And always remember, you often don't just biopsy one side, you biopsy both sides as well. And remember, biopsies can sometimes be negative because they may be skip lesions that you may miss the inflammation,
Yeah.
typical of arteritis.
Yeah.
So,
and that's why you could still have you can have a diagnosis even with a negative biopsy if you fit the other criteria, because you may have biopsied a
exactly.
normal area of the artery. Yeah.
Yeah. So I'm just going to throw a bit of a spanner in the works here, because otherwise we won't, I guess, be talking about the case. So, and that is exactly what happened, Ben. You're spot on. We started on high dose steroids. There was no visual involvement. There was no visual changes. So we started on 60 milligrams of prednisolone, booked in for an ultrasound scan and for a biopsy as soon as was feasibly possible, and for an urgent rheumatology opinion. Absolutely. And that was done.
Okay.
Now, she's not quite, which was very reasonable, and probably if the same case presented tomorrow when I'm back in SDEC, that is exactly how I would manage it. Now, I'm just going to give you a little bit of background here, bit of past medical history. Now, she's known to be hypertensive, and that was where her concern about having a stroke came from. Although she had no weakness, it was more pain. She also had depression, anxiety, psoriasis, and she was HIV positive. She also had a hiatus hernia. What's significant about that is she'd been on highly active antiretroviral therapy for many, many years and had a HIV count which was very low. So her viral titer, her viral load, was insignificant. So really, her HIV wasn't active and it wasn't causing any problems. Now, over the last sort of few months, because of a hiatus hernia, she was really struggling with taking the tablets for the highly active antiretroviral therapy because of the size of them. She felt they were very big and they were causing quite some significant dyspepsia. There was a forward management plan between her and her sexual health doctor, how best to manage this. But she didn't have an up-to-date viral load. And I was asked to see her yesterday because something had changed. Does that, what I've told you, does that get you thinking or worrying or?
What do you mean about something had changed? You saw it?
Yeah, so she came in yesterday. I guess it hadn't changed because she'd been on high dose prednisolone and the headache hadn't changed.
Oh, okay. So there was no improvement.
No improvement. And
Um,
it's been 72 hours of steroids.
hmm. So if somebody came in, let's start again with a new fictional patient. If somebody came in
Okay.
with a severe headache in the context of known untreated or suboptimally treated HIV, that would
Okay.
reset my threshold for doing cross-sectional imaging, because in very immunosuppressed patients, you can get infectious conditions such as cryptococcal infections, which can cause severe headache and raise intracranial pressure. Um, I think that I don't know in her case whether she is in that particular situation, but that would make me change a little bit. I vaguely remember that having a untreated, and to emphasize untreated HIV, not treated HIV, is it means that you've got very similar risk profiles for
Yeah.
compromise and all that as the general population. So untreated is a red flag for severe headache. So maybe that's why, as well as looking at the HIV viral load and all that sort of thing, I'd be maybe thinking about doing a CT scan a little bit earlier if I thought there was the potential for a CNS infection, which has led to
Okay.
her presentation. Yeah, that's the only adjustment I would make there, I think.
Now, she was actually seen by a different doctor yesterday, as well as myself. So slightly different clinical setting. And the doctor who initially saw her yesterday started from the beginning again. And,
Yeah.
just as you said, actually, with a little bit more information. And I guess the worrying point is normally giant cell arteritis, the pain does get better with steroids.
Yeah, quite quickly as well.
Quite quickly, the patient would start to feel better in themselves as well. But she didn't actually. She still had the flu-like symptoms, the runny nose, and actually the left eye was now a little bit injected. So there was some redness around the eye.
Mm,
There was a little bit runny around the eye. And she says that the headache was still there. The vision in the left eye was a little bit blurred, and that wasn't there before.
mm.
So was this giant cell arteritis that was just undertreated? That was what we started to worry about. She said that those pain was still there, but actually she was feeling just generally tired, and noticed that she was itching around this area.
Around what area? The area of the headache?
Sorry, I'm pointing. Yeah, it's
Oh.
not very well.
We're on video now, so that would have worked on in a
Okay,
visual.
so she was itching in the left temporal region where the pain
Oh,
was previously.
she's got zoster.
She has zoster.
Yeah, she's got ophthalmic shingles, right?
So the when we examined her, she had vesicles
Mm,
typical of herpes zoster
mm,
ophthalmicus in that region.
mm.
Absolutely.
That's so funny. The reason I jumped that so quickly is because I
Yes.
had a very similar case about 6 months ago of someone who came
Oh.
to me in ESTEC with excruciating pain in a
Mhm.
dermatomal region, and it was like T something. And I said, I think you're about to get vesicles in the next few days. I think this is early zoster because the neuralgic pain can precede the vesicle eruption.
Absolutely.
So yeah, and that's why and I gave that particular patient acyclovir and said, I bet you my mortgage you're about to have an outbreak of shingles in this exact area, but you just haven't got the vesicle stage yet. That's why I jumped to that so quickly.
Yeah, it's really interesting because if somebody presents with temporal pain, then you like you said in originally, giant cell arteritis is a medical emergency and can affect the vision. So we need to treat as that. And because there were no vesicles or in that prodromal state, you couldn't see anything.
Mhm.
And would we do anything differently next time? Probably not. But when you looked at it, yes, clearly there were vesicles. And actually, she describes the pain as shooting into her ear, into her scalp. Then the question I asked myself was, could she still have giant cell arteritis as well?
Ooh, so you've got your Occams versus your Hickams.
I know. So, because Hickham's dictum is my favourite thing. Patients can have as many diseases as they damn well please. And her ESR was 100. So I was then having to make the decision, do I stop the steroids, which could be making the herpes worse anyway? Or is this giant cell arteritis? Do I still need to do an ultrasound? Do I still need to biopsy this? Or am I confident that this is zoster and I can give her acyclovir?
I tell you what I would have done.
Go on then, Ben.
I would have binned off the temple
Okay.
arteritis and said,
Okay.
okay, I found my diagnosis now. Everyone,
Okay.
as you were, stop the steroids, no biopsy, and let's just give the acyclovir and see how we get on.
Why?
Because I am very compelled by a good diagnosis. Sometimes when your diagnosis is vague, or when you have a
Mm,
punt and you say, I think it may well be this, it
mm,
could be this, but option A is a bit more likely than B, then that's
mhm.
when I get a bit, maybe we should treat A and B and then watch.
Okay.
But when I have a definitive diagnosis of A, I feel so much more secure in saying, okay, we
Yeah.
can forget about B. I just, and it's absolutely possible, anything in this universe is possible for someone to develop acute zoster eruption in the exact same location, both geographically and temporally, as a new diagnosis of temporal arteritis. But those odds are so
Mhm.
low. I'm quite satisfied to just get rid of
Yeah.
the temporal arteritis diagnosis. And remember, I mean, as you well know, temporal arteritis is actually a rare disease. It's
Mm.
rare. It's not common by any means. I forgot what the number is. It's like 0.02% of the population or something, but it's a very rare disease. So to have it in isolation would be, what an interesting one for the books. But to have that with
Yeah.
an acyclovir, I mean, that sort of lottery ticket territory of probability, to me, and that's
Yeah.
why having definitive proof of this diagnosis, I get rid of the other one.
Yeah. And that is what I did. Um, however,
I know.
well, however, it because I don't know whether it was because it was 4 o'clock in the afternoon and I'd seen a lot of people. It's very noisy. It's very busy. There were lots going on. I felt making that decision quite difficult.
Mhm.
Whereas maybe if I'd seen the patient in a clinic setting and it was very
Mm.
quiet and it wasn't very busy, maybe I would have been able to make that decision a little bit quicker and been a bit more happy with my decision. Um, but I think it took me a long time to come to that conclusion. Um, because processing decisions at the end of a shift, we've talked about this quite a bit before, it's
Mm.
much more difficult to processing them at the beginning of the shift. But then sometimes I have to write down my rationale and I'm like, of course this is zoster.
Mhm.
The chances of getting zoster and GCA at the same time
Mhm.
are so low that if it did happen, then that would be a paper to write up.
Yeah.
Um, and I guess then the question that I then started to ask was, is this patient immunocompetent or is she immunocompromised? Because we don't know what her current viral load is. And obviously, zoster in somebody who's immunocompromised can spread incredibly quickly, can cause very significant visual problems, and has a high mortality and morbidity rate associated that with it, and would need admission for intravenous medication. Or was I confident that she was immunocompetent and happy to go down the 800 milligrams of acyclovir a day, 5 times a day? It was, again, that was a difficult decision as to where I go. What would you have done?
I'm saying this to you in the cold light of day, sitting in my kitchen with a patient that I'm one step removed from. So I'm very clear. I would have given the acyclovir. Of course, I would have checked the HIV status and make sure that she was plugged into an HIV follow-up clinic for ongoing care. Absolutely. Yeah. But sitting here and now, I wouldn't have lost much more sleep over it than that. But I understand what you're saying. When you're in a clinical environment, I do sometimes get a bit paralyzed between what's the least injurious thing to do here. The one that comes into my head is a few weeks ago, and I was on a ward round, and I had a patient, a much older a woman who had come in with a head injury, and she had PEs and an intracranial bleed because she fell over. Do you anticoagulate the PEs or not, because she's got this stable subdural traumatic hemorrhage? And I was really paralyzed for a while, and I was going my ward round, and I kept saying to the SHO, I was going, well, I still haven't decided about that patient. I'm like, let's see a couple more patients. I'll decide at lunch. No, what we'll do is we'll finish this ward round, we'll have a cup of tea, and I'll know exactly what I'm going to do. So we do that. I had a cup of tea. I was like, I still haven't made a decision about this. I might sit with it a little bit long. What would you do? What would you do? And eventually at the end of the day, I came back and went, I've decided we're not anticoagulating. We're going to leave it for a couple of weeks, and I'll go and tell the patient all the risks and that. And the SHO said, that's what I would have done as well. I was like, well, some use you were. I took the last 5 hours. I've been eating my heart out trying to decide, but thanks anyway. It's for the endorsement. But sometimes you do need to let it simmer. Sometimes it simmer in the back of your mind for a little bit, and then the answer comes to you. And it's not very often that we have to make a decision right here, right now, that's very instant. Usually we can sit with it for a little bit of time, even for a few hours. If you absolutely can't do that, then I go around asking people. So I just speak to my consultant colleagues who are very co-located. We got an aesthetic consultant, a take consultant, Amie consultant just up the stairs. So I'll go around and say, I've got a real humdinger. What would you do in this situation? And I'll maybe get, the three wise people's opinion, and then sort of come forward from it that way around. And it makes me feel a bit better that I'm not just going mad and doing something that other reasonable people wouldn't do.
I completely agree. I mean, today I've been asking my colleagues, what would you do? How am I going to do this? From actually probably sometimes quite simple things, but you get decision fatigue, don't you? And sometimes you just want to check in and say, this is what I've done. Does that sound reasonable? That flucloxacillin 2 grams IV for that condition. And I think it's that also shows a bit of self-reflection. It also learns, and it's really good to, again, foster that type of relationship with your colleagues as well. Because patients are, and the people that we're seeing now, there's a lot of multimorbidity. People are very complex, and putting all that together in a busy, noisy environment can be difficult.
Well, that's why our specialty exists, because people are multimorbidity. I mean, where do you park these people under which ology, which specialty? Whoops, it's not a rheumatological, it's an ID condition. Now, we got to change teams. That's why acute medicine, in general medicine, which we both love, exists because we can adapt to different pathologies in theory. So that's one of the reasons why we both like our jobs, I guess, the variety.
Yeah, absolutely. And I think there is more variety. I'm seeing more and more things that I probably wasn't seeing 10 years ago. I don't know why that is, but it just is. But I also do think that, I don't know whether it's because I'm getting older, but I am struggling with making decisions more. And I don't know whether that's because I'm aware of the consequences of what could happen if things go wrong.
You've written enough reports and attended enough after action events to have seen when things go wrong.
Exactly. So I think instead of being much more confident in my decision making, which I probably was when I was the first or second year registrar, maybe a little bit arrogant with the decisions I was making, I wasn't aware because my knowledge and experience wasn't there. I'm not saying my knowledge is perfect, because it isn't. I'm still, even today, I was learning new things, but I know a lot more than I did.
You know, that is so true. I was way more confident when I was the
Yeah.
med reg than I
Yeah.
am now. I have a much more slow and
Mm,
steady wins the race
mm,
approach to things now. And sometimes I think of the decision making and the things I did when I was med reg.
mm.
This is my opinion at the time, running the show, running the
Yeah.
hospital. And I was like, you lucky so and so that didn't go blow up in your face,
Yeah.
or this didn't happen, because I've seen and I've collected enough of a library now when things go wrong. Things go right 99% of the
You
time,
do.
but I've
Mm.
seen some of the 1% now, which probably makes me a little bit more cautious and makes me sort of fall into those heuristics we can cognitive reason we have, which is like, if in doubt, do not.
Mm.
Give the patient time. The answer will become clear. The diagnosis will reveal itself. Whereas when I was a reg, I was much more, come on, we've got to sort this out now. It's one
Yeah.
thing or the other. Let's bung a bit of metoprolol and then we'll see what happens and maybe work out what the rhythm is,
Mm.
you know.
Yeah.
And I don't decry that in registrars now. I think that's probably a very normal part of professional
Yeah.
development. And
Absolutely.
I
Yeah.
don't to argue against that. And if anything, I say enjoy that period, because that was fun to me, the med reg role. I was having fun doing
Oh, I
that.
loved
And
it. I
I just
loved being the med reg.
want to emphasize here, I was never dangerous, just in case you were listening with their mouths hanging open. I was never, did anything outside reasonable activity. But yeah, I had a slightly different approach than what I do now. But that's
Yeah.
why I liked going into work then and being the med reg.
Yeah. Which even now, on some days, I still think it's the best job. I
Mm.
love being the med reg.
Yeah, I did.
I felt like I ruled the world.
Yeah, I did.
Um, and I just, I know people fear the role, but it is just a wonderful,
Yeah.
wonderful role. It's challenging
Yeah.
and
Tough
it's
though, tough.
tough.
It
It is
was
tough.
when
Yeah.
on the bad days they were really tough bad days, but the good days were very, very good.
And you walk out
Yeah.
floating on air and you've had a good day. You feel like
Yeah, yeah,
I
yeah.
did a really good job today. Yeah.
I
Which still
agree.
happens. But I guess because of the onus of responsibility as a consultant, things are slightly different. My perception is different, I guess. So,
Yeah. I
yeah.
also like to now as a consultant, I quite like to display I don't know. I
Oh,
like
yeah.
for
My
the
favorite line.
I like for the doctors who I'm supervising or whatever, I like them to see me get stuck and ask other
Yeah.
people for their opinion, because I want them to know that this is a normal part of being a reflective practitioner and it's okay to do, and you haven't got to go away and come up with all the answers on your own. And sometimes groupthink works. So sometimes, I mean, I don't have a problem with saying I am absolutely stuck on this. I'll make a decision later, but what do you think? What would you do? And even if they don't want to tell me, but I want them to see me asking around.
Yeah. It's really important to have team decision making. With cases I was seeing today, some quite complicated and well patients, and I've asked, "What would you do? Any of the questions you want to ask?" And they're like,
Mm.
"No, anything you'd like to do." And actually, a patient I saw today, we may discuss in a future podcast because again, a lot of learning points. But the registrar I was on with said, "I think we need to look for this," and I was like, "Hadn't thought of that. You're
Yeah,
absolutely right.
yeah,
We cannot give that medication I've just prescribed. We need to stop that, and we need to rule that out ASAP in a very sick patient." Hadn't thought about it because I was so focused on something else. So it was really important actually to ask around
mm,
and respect people's opinions as well.
mm. One last thing before we sign off. We talked about decision fatigue, which is very real.
Mm.
What do you do when you've realized that you cannot make another single decision? What's in your rescue box?
I have a so I go one of two ways. I either go one and pretend that there is nothing wrong, and I start to act like um it's fine. I can carry on. I can clear any. I can see every patient. But actually, I'm not making any decisions because I'm just wandering around writing things down and faffing about. Um, that's never a very good option. And sometimes people will be like, Amy, come on. And actually, a few weekends ago, a colleague of mine had a similar situation and she went into the office and read a book that was nothing about medicine for 20 minutes and completely took her mind off it and had a cup of tea and brought some chocolate. So it's 20 minutes
Yeah,
taking you away from that space because we knew we still had 3 hours left of the
yeah.
shift.
That's
It's
similar
not an
to me.
option.
It's similar to me.
Yeah.
I recognize it myself after a
Yeah.
long after when you finished a 12-hour shift and you've made
Mm.
about 5,000 decisions of different sort of intensity throughout
Absolutely.
the day. I've had a complete nervous breakdown in the aisle at Tesco's because I don't know what to buy for my dinner because I've run out of decisions. But when I'm in the job, And I realized, and people are asking me questions which probably are quite straightforward. And I'm just saying, I don't know. I don't know, man. I don't know, because I cannot make the decision.
You can't make it.
I found the only thing that works for me is I have to go somewhere and be quiet.
Mm.
Go and be quiet somewhere for 10 minutes.
Yeah. The
The
toilet.
break room, the loo, the sluice. I just have
Yeah.
to go and be somewhere quiet
Yeah,
and
I
not
agree.
speak. And when I come back, the dust has settled a bit, and like the noise inside my head has sort of come down a bit. And then I go, okay, I've got it. Then I reach down and find a few more decisions that I can make. So
Yeah.
that would be my advice to anyone, to try when you recognize you're in decision fatigue territory and you can't decide anything else. You have to go and be quiet.
Yeah.
And if you want a cup of tea, that's fine. You want to scroll on Instagram on your phone, that's fine, or read your book. But I think the going away and being quiet is key.
Yeah, I completely agree. And you said, many episodes ago now, when I'd messed up with a patient, never see a new patient in the last 30 minutes of your shift.
Mm,
And I live by that now.
mm,
So I'm like, I'm not going to see another patient because
mm,
it doesn't matter. Like Ben told me, never to see another
mm,
patient in the last 30 minutes.
mm.
And it makes a massive difference.
Yeah, yeah,
Because if I pick somebody up 50 minutes before, I don't finish work on time. I then get really grumpy.
yeah.
So that one piece of advice that you gave me is probably one of the most important pieces of advice I've got in the last couple of years.
Let me qualify it though as saying never pick up a patient in the last 30 minutes of your shift solo. I have broken that rule recently.
Yeah, okay.
When it was me and another doctor, me and I don't know, an F1 or something. And I said,
Okay.
30 minutes left, patient, chest pain, ED. I've done a really good clocking already, ECG
Okay.
blood. I think we can do the 30. Come on, let's
Do
do
it
it. Shall we do
together.
it? Shall we do it? Let's do it. Oh my gosh, we must be mad. And we've gone and we've done it and finished on time. So only do it if you're going in as a team. But otherwise, yeah.
Yeah. Okay. And also because we work shifts as well, sometimes you might have a doctor who's been in hospital for half an hour, much more fresh, much more on it. And that's often a good way to work. But you're absolutely
Mm.
right. Thank you. Thank you for advice as ever.
You're welcome.
So thank you. One thing, what one point do you want to take away from today?
Let me go backwards. So my first thing, I'll go backwards in time. The thing about being quiet when your brain is saturated, your cognitive bandwidth is about to crash. You have to go and be silent somewhere. Then moving backwards from that. Okay, going back to the clinical case. Yeah, I think what we were talking about playing the probabilities, playing the Bayesian sort of likelihood of someone having two diagnoses, one of which is relatively rare, or have they got one good diagnosis, and being able to let go of your first diagnosis when new information comes along. We talk a lot about sort of cognitive bias here, and there's something called the anchoring heuristic, whereas you drop anchor on a certain place and a certain thought, and you will not lift anchor because you're stuck on it. So being adaptive to new information as it comes in, and having no problem with saying goodbye to your first diagnosis if now you know better.
Yeah, absolutely. And I think with this case, I'm not sure I would do anything differently again. If I had presentation, left temporal pain, worried about visual loss, I think you would go down the GCA route anyway.
Yeah.
And I think that's reasonable. But next time, think, oh, actually, could this be zoster? Have a real close look. Is there anything in the ears, and just be a bit more mindful of that. Absolutely. Thank you as ever, Ben. Brilliant.
Thank you.
Please, everybody who's listening, rate, review, share the podcast with anybody who think would be interested. And we will be back very, very soon. Thanks for listening.